Hi, my name is Matt Rettig. I'm a genitourinary medical oncologist. I work at the David Geffen School of Medicine at UCLA, also known as UCLA School of Medicine. So the question is, what factors are predictive of survival for patients with urothelial carcinoma who are starting immunotherapy after platinum-based chemotherapy? So let's first start off by defining some important terms. Urothelial carcinoma. Those are carcinomas of the urothelium. That's or the transitional epithelium. We used to call them transitional cell carcinomas. The most common primary organ is the bladder, but also can occur in the proximal urethra, the ureters, or in the renal pelvis, with the bladder being the most common site. So prediction and prognosis, these are other important terms. When a factor is predictive of outcome, of survival, that's called a prognostic factor. When a factor is predictive of a response to treatment, that's called a predictive factor. So what we're talking about here is patients who've had platinum-based chemotherapy for metastatic or locally advanced unresectable urothelial carcinomas, again, most commonly carcinomas of the bladder. In those patients, the factors that are prognostic are several. They're all called the Belmont, B-E-L-L-M-U-N-T, risk factors, and they include performance status. So an ECOG performance status of 2 or more is bad. Hemoglobin less than 10. Visceral organ involvement, so liver involvement especially, but also bone involvement is a poor prognostic factor. Patients who have lymph node only metastasis, so metastasis outside of the pelvic regional nodes and the retroperitoneum or the mediastinum as example sites, have particularly good prognosis. And also the time from the completion of the platinum-based chemotherapy to the initiation of immunotherapy is another important prognostic factor. So those are the prognostic factors. What we're talking about with immunotherapy are checkpoint inhibitors. And there are 2 key checkpoint inhibitors that can be used as second-line therapy after platinum-based chemotherapy. One is pembrolizumab, which has been shown in a phase 3 study to yield improved overall survival as compared to second-line chemotherapy. And the second one is nivolumab, which has been shown in phase 2 studies to yield reasonably high response rates, but has not been compared yet head-to-head with cytotoxic chemotherapy. I should point out that there's another checkpoint inhibitor known as avelumab, which was recently approved not for patients who have failed and progressed after platinum, but as maintenance therapy after platinum-based chemotherapy, cisplatin or carboplatin. And that was recently published in the New England Journal, and the study is called Javelin. But I'll be focusing on immunotherapy, checkpoint inhibitors, namely pembrolizumab and nivolumab, as second-line therapy after platinum-based chemotherapy. One more caveat: the other agents that should not be used, even though they are checkpoint inhibitors in the second-line setting, are durvalumab and atezolizumab. So durvalumab and atezolizumab are both PD-L1 inhibitors, and pembrolizumab and nivolumab are both PD-1 inhibitors. So these agents can both be used in the second-line setting. The prognostic factors that I mentioned initially apply here, and that is performance status, hemoglobin, visceral organ involvement, and finally, the period of time from the completion of platinum-based chemotherapy to the initiation of checkpoint inhibitor therapy, with a threshold being 3 months. Less than 3 months is bad, more than 3 months is good. There are also predictive factors. That means, what are the factors that are associated with a benefit from the initiation of the immunotherapy? So some of the prognostic factors are also associated with response and benefit from the immunotherapies. With that said, there are none of the factors that are prognostic of overall survival that should be used to exclude patients for immunotherapy, unless the patient has a poor enough performance status that they're not suitable for such treatment. Finally, I think it's important to mention the PD-L1 expression status. So PD-L1 expression is associated with higher response rates to immunotherapy in urothelial carcinoma when used second line. However, PD-L1 expression is not required to initiate such therapy, and patients who are PD-L1 low or negative may still benefit. The cutoff for PD-L1 high and low is generally about 10% for patients who are undergoing immunotherapy with a checkpoint inhibitor after platinum-based chemotherapy. So those are the prognostic and principal predictive factors for immunotherapy after platinum-based chemotherapy in patients with urothelial carcinoma.